and welcome to the Opportunities for Collaboration and Partnership between WIC and MIECHV to support Child and Family Health webinar. As you log into the webinar, please take a moment to fill out the poll to tell us your role in WIC, MIECHV, or tribal home visiting. Next slide, please. My name is Kelsey McCoy, and I'm a supervisory team lead for the Division of Home Visiting and Early Childhood Systems in the Maternal and Child Health Bureau at the Health Resources and Services Administration. I'm joined today by SAVANNAH Sparker, nutritionist in the Supplemental Food Programs Division in the Food and Nutrition Service at the U.S. Department of Agriculture, who will help facilitate today's webinar. We have a number of presenters today who will be introduced later in the webinar. Next slide, please. Before we begin the presentation, I would like to review a few webinar logistics. First, please note this webinar is being recorded. If you do not wish to be recorded, feel free to disconnect now. You may listen to the presentation to the Zoom platform or call in using the call-in numbers, but all participants will be muted during the presentation. During the presentation, we encourage you to use the Zoom chat function to ask any questions you may have. There's no need to hold your questions until the end. After the presentation, we will take a few minutes to answer the questions we have. Time permitting, we will answer as many questions as we can. A link to the recording of this webinar will be sent to awardees through their respective program listservs and posted on the USDA website. Next slide, please. If you would like to turn on closed captioning, please select Live Transcript at the bottom of your screen. Next slide, please. Now that we have the webinar logistics covered, let's review our agenda. First, we will have a welcome from the federal partners who collaborated to bring you today's webinar. We will then welcome representatives from Montana WIC and Montana MIECHV, the Port Gamble Skelem Tribe, and Georgia WIC and MIECHV to share with us how they have partnered to leverage or enhance Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, Maternal, Infant, and Early Childhood Home Visiting Program, MIECHV, and Tribal Home Visiting Services. Following their presentations, we will have a discussion and take questions. Again, there's no need to hold your questions until the end. You can enter them into the chat box throughout the presentation. Next slide, please. Now let's begin with a welcome from our federal partners. Cindy Phillips is the Director of the Division of Home Visiting and Early Childhood Systems in the Maternal and Child Health Bureau at HRSA. Sarah Vidor is the Director of the Special Supplemental Food Programs Division within Supplemental Nutrition and Safety Programs at the Food and Nutrition Service. Oshme Beltengati is Senior Policy Advisor for Tribal Early Childhood Development and Tribal MIECHV Program Manager in the Office of Early Childhood Development at the Administration for Children and Families. Cindy, over to you.
Thanks, Kelsey. Hi, everyone. I'm excited to join you to discuss the ongoing collaboration between the Health Resources and Services Administration, HRSA, Maternal, Infant, and Early Childhood Home Visiting Program, otherwise known as MIECHV, the Administration for Children and Families Tribal Home Visiting Program, and the USDA's Food and Nutrition Service WIC program. As you may recall, the USDA Food and Nutrition Service and the Health Resources and Services Administration issued a joint letter in January of 2021 encouraging state and local agencies and grantees that operate WIC and MIECHV to collaborate and develop shared strategies to improve maternal and child health outcomes. Today's webinar is an opportunity to expand on that letter and to highlight promising examples of collaboration at the state and local levels. Just a little bit about MIECHV. Since 2010, the MIECHV program has empowered families with the tools they need to thrive. The program supports evidence-based voluntary home visiting for pregnant women and families with children up to kindergarten entry living in communities identified as at risk for poor maternal and child health outcomes. Home visiting helps prevent child abuse and neglect, supports positive parenting, improves maternal and child health, and promotes child development and school readiness. Last year, the MIECHV program served 140,000 parents and children across all 50 states, DC, and 5 US territories. Anecdotally, we know that WIC is one of the largest referral sources for MIECHV, which speaks to the ongoing collaboration efforts of state and local MIECHV and WIC programs. We don't need to tell you that state and local MIECHV and WIC programs are well positioned to collaborate, as both programs share a common goal of improving health outcomes for very similar populations. Many of you have been doing this for years. Through review and analysis of MIECHV funding applications, we have found that a majority of MIECHV state programs reported collaborating with WIC as a formal referral partner. In fact, some MIECHV local programs receive most of their referrals from WIC, and some have even developed shared referral forms and systems. 1/3 of awardees reported having formal MOUs with WIC to support collaboration between the two programs. Some awardees reported that their MIECHV and WIC programs were either co-located or administered by the same overarching department. And still other states reported collaboration between the MIECHV and WIC programs through shared professional development or training opportunities. Our hope is that our collective efforts at the federal level will help support and further your work. We'll just mention a few opportunities to make you aware of. In March 2021, HRSA awarded approximately $40 million in American Rescue Plan funds for MIECHV awardees to support home visiting activities that address the immediate needs of parents, children, and families related to the COVID-19 public health emergency. HRSA will also be awarding an additional round of ARP funding, and this time to not only address the ongoing COVID-19 related needs, but also expanding services to more families. And then HRSA recently released a fiscal year 2022 Innovation Award notice where we expect to award $22 million for up to 11 awards for states, territories, and nonprofit organizations to implement data and technology innovations. We encourage state and local MIECHV and WIC agencies and grantees to establish or expand partnership using these new and existing opportunities with the ultimate focus on leveraging and enhancing existing services to families. And with that, I will turn it over to Sarah Vidor.
Great, thanks, Cindy. Hello, everyone, and thank you for joining us today. My name is Sarah Vidor, and currently I am on a special assignment leading the development of the framework and implementation plan for the WIC modernization funding authorized in the American Rescue Plan Act. When I'm not on special assignment, I serve proudly as the director of the Supplemental Food Programs Division within the Food and Nutrition Service, an agency of USDA. As a division, we are responsible for administering the WIC program as well as the WIC Farmers Market Nutrition Program and Senior Farmers Market Nutrition Program. We are grateful today for both HRSA and ACF's partnership with us at the federal level and for the opportunity to collaborate in creating today's webinar to highlight the importance of establishing community partnerships between MIECHV and the WIC program. Through the WIC program, we work with state and local agency partners to address the supplemental nutrition needs of at-risk, low-income pregnant, breastfeeding, and postpartum women, infants, and children up to age 5. As many of you know, WIC provides participants monthly supplemental food packages targeted to their dietary needs, breastfeeding support to nursing moms, nutrition education, and referrals to a range of health and social services. All benefits that promote a healthy pregnancy for mothers and a healthy start for their infants and children. It is an exciting time for the WIC program. The American Rescue Plan, also known as ARPA, provided USDA FNS with funds to temporarily increase the cash value benefit to WIC participants for the purchase of fresh fruits and vegetables. The feedback from WIC state agencies and participants has been extremely positive on this increased benefit. Additionally, ARPA provided USDA FNS with $390 million to carry out program modernization efforts to increase participation in the WIC program and increase redemption of benefits by WIC participants. We look forward to the impact these efforts will bring to the WIC program. The mission and goals of MIECHV and WIC certainly complement each other and work to improve the health outcomes for their respective participants. Since both programs are in contact not only with the mothers, but also with caregivers, parents, siblings, and other friends and families, we are in a unique position to help our mutual program participants reach better health and well-being. The joint letter signed in early 2021 reestablished our interagency partnership between WIC and MIECHV. At the federal level, FNS and HRSA continue a partnership through regular meetings to identify opportunities to share and promote promising practices across programs, and we certainly encourage state and local WIC agencies and MIECHV grantees to establish and expand their own partnerships. Today's webinar will be especially helpful in providing ideas about successful collaborations between these two vital programs. Like many of you, I am looking forward to hearing from our presenters today and hope there are examples of partnership-inspired continued collaboration between the agencies you work for. I wish you an informative and successful webinar. I thank you for the opportunity to participate today, and now it is my great pleasure to turn it over to oshme from ACF.
Thank you, Sarah and Cindy. It's a pleasure to be with all of you today to talk about the important topic of collaboration between MIECHV and WIC. My name is oshme Beltengati, and I work in the Office of Early Childhood Development at the Administration of Children and Families, where I've served as the program manager for the Tribal MIECHV program for over 10 years. As Cindy and Sarah have shared, our programs have a common mission of supporting the health and well-being of young children and their families. Our programs are also embedded in communities and part of a broader system of care and support for families. I think often people in early care and education and home visiting do not think about nutrition programs as being a key part of the early childhood system, but we've seen, and we'll hear about today, that WIC in particular is a critical partner for home visiting programs and vice versa. I am speaking from the perspective of the Tribal Home Visiting Program. Since 2010, the Tribal MIECHV program has served thousands of families and provided over 123,000 home visits to expectant families and families with young children from birth to kindergarten. Last year, our program served over 3,300 caregivers and children. We have seen in the Tribal MIECHV program that WIC is an essential partner, and you'll hear from one of our grantees today that administers both their home visiting program and their WIC program using the same team, and has had great success as embedding both programs into the essential system of support for families. But many of our programs work closely with WIC and refer families to each other's programs so that the families can get the supports they need. Tribal MIECHV and WIC programs also work toward shared goals. One of our grantees, an urban Indian health agency in Phoenix, has a strong commitment to nutrition and health among its Native American clients and has received awards for innovation and best practices in reducing food insecurity. Both WIC and MIECHV have contributed to this and work closely together to support families with young children. During the MIECHV Community Needs Assessment at this organization, they found that 38% of participants were worried about buying or running out of food, and that it was hard for home visitors to focus on helping families meet their goals if they were worried about having enough to eat. So the programs have partnered along with other community and agency partners to implement a variety of activities focused on health and nutrition, including developing group activities for families where they receive food packages and get a chance to try out recipes using traditional foods. Other tribal home visiting and WIC programs have partnered closely to promote breastfeeding or share information with families about healthy nutrition, and especially ways to integrate cultural and traditional practices in the work they do to support families. Both Cindy and Sarah mentioned the American Rescue Plan Act, ARPA, and we were also pleased to provide supplements to our Tribal MIECHV grantees a few weeks ago to help meet the needs of families during the pandemic. Some of them are focusing their efforts on getting emergency supplies, including food and formula, to their families, and Tribal WIC will be a key partner in those efforts. Thank you again for being with us today. I know our speakers will share innovative strategies, ideas, and best practices that will help us all think about how to maximize our partnerships to better support the children and families we serve. Now I am pleased to turn it over to my colleague from FNS, SAVANNAH Sparker, to introduce our panel of speakers.
Thank you, Cindy.
Savannah, I'm not sure we can hear you.
Oh, I'm so sorry. Thank you. I thank you, Cindy, Sarah, and Moshmi for your thoughtful welcome and framing remarks. We will now shift to the presentations for examples of WIC, MIECHV, and tribal home visiting collaboration. Next slide. Our first presentation is from Montana WIC Program and MIECHV Program, known as Healthy Montana Families. Kate Gerard is the Montana State WIC Director and Section Supervisor. Leslie Lee is the Montana MIECHV Project Director. I will now turn it over to Kate and Leslie.
Thank you, Savannah. This is Kate Gerard from Montana WIC. I am very pleased to be here, very honored to have been selected and recommended by USDA and HRSA to present today. We'll be talking about our collaborations here at the state and also featuring some of our local level collaborations. I just want to highlight here, this picture on our entry slide is of one of our WIC families on the Rocky Way Reservation. And it's a real honor. We've had some great success in getting local agency stories and pictures to use in our presentations and enjoy featuring our families. Advance, please. Next slide. Oh, thanks. So just a little bit about Montana for those of you not fortunate enough to have visited here. Montana is a fantastically beautiful state and has many, many wonderful qualities, which are highlighted here on this slide. Not only are we one of the largest geographic states, we have one of the lowest populations, which means we have a very, very low population density, and a great amount of our state is considered rural. And I would bet most of you would consider our entire state rural, even our largest quote unquote cities. We do have about 2.5 times the number of cows as people, if that tells you anything. It's a highly agricultural state. We have dinosaurs, bones easily found under our grounds. We have beautiful national parks, beautiful gems that can be dug out of our streams. Some great little fun facts here, including the river runs through it was filmed here, if that tells you anything about how beautiful this state is. Along with that, just to highlight, we do have 8 federally recognized tribal nations in Montana. 7 of them have designated reservations, and the 8th is the Little Shell Tribe, and they were just federally recognized in 2019 and are building up their reservation and their capacity to serve their people. So those are very, very close partners of ours at the state, and bring a lot of culture and connections throughout our state. Advance, please. This is, I have a few slides about data that we have put together in a recent needs assessment for WIC. This is WIC specific data, but of course, WIC and MIECHV serve very much the same population. So this very much does describe the population generally in WIC. So in terms of our racial and ethnic data in WIC and Montana in general, you'll notice that our race is primarily white. Statewide, it's almost 90%, with roughly 7% identifying as Native American, American Indian. And in the WIC population, we have a much higher proportion of Native American, American Indian participants at nearly 25%. And about 67% is considered white, and then 6.1% other, and that's a combination of all of these other races here. Our ethnicity, primarily non-Hispanic, with 93% considering themselves non-Hispanic. in our Montana WIC participants, and in the state, over 96% non-Hispanic. So I thought this was interesting because I know a lot of our states are a lot more diverse than Montana. And so I think it can paint a little picture about the state of Montana and our people. Advance, please. As with many, if not all, WIC agencies, our participation has been in decline for really about 10 years. This is 5 years of data that we are visualizing in our needs assessment to show the decline in our participation. And this is from a sample month from, you can see April 2016 to 21. We have declined from, over 18,000-ish people down to about 14,000, which is where we are today. That is not unique to Montana. That is a nationwide trend, and I can't say exactly why that may be happening. We have a lot of theories, but what we do know is that it's not because people don't qualify. It's not because our population is reducing drastically, although the growth rate is a little bit down, and there are some figures like that you could point to, but we do know our potentially eligible population is fairly consistent, and we're only meeting about, you'll see actually on the next slide, you can advance, we're reaching about 50% of our potentially eligible population. So this is for Montana specifically. The percentage to the right of the bars talks about the estimated percent eligible in the state. So you can see a range of 48 to 54% here. And we, over the years, have been reaching less and less of our potentially eligible. And that just means to us that there's so much more we can do to reach these families. One of the characteristics I would say about Montanans is that they are staunchly independent, and they like to take care of themselves, and they don't ask for help very easily. That's a broad generalization, but that is part of our theory why up here in the Mountain West states, we tend to have a lower reach to our potentially eligible population. It's not for lack of trying. We do lots and lots of outreach, but the big part about participation, as many of you know, is it's recruitment. It's letting people know if they're eligible, how to access the program, and how to benefit from the program. And retention. Once they enroll in the program, keeping them on as long as possible so that they benefit the most from the programs. The way we primarily do both of those things is by working with our partners. We know that our number one referral system is what we term word of mouth, and that could be really general. It could be friends and family. It could definitely be referrals from other programs. And then beyond that, it's mostly providers, healthcare providers and other programs referring into WIC. So in my position, and I expect in all of our WIC state and local positions, a huge part of our jobs is collaborating with other programs that serve the same population. And I just call it making friends. I make friends with all of the leaders and as many people as I can who serve the maternal and child population in Montana and have a vested interest in the same types of issues that we do. Advance, please. Oh, I think we skipped on there. This data is very interesting, and I'm just going to describe it a little bit, although it's a little bit complicated. This is the top 10 counties in Montana that are considered most at risk from a health outcome perspective. And I believe that this is actually from several data sources. So when we release our needs assessment here in the next month, it'll be widely available and you'll be able to see where all of this data comes from. But essentially what it's showing is that in our top 10 counties for need, where there's the largest health disparities and quite frankly, the poorest health outcomes, it also overlaps with many of our tribal reservations. As you can see, Bighorn County overlaps with Crow, Roosevelt overlaps with Fort Peck, Rosebud overlaps with Northern Cheyenne, and so on and so forth. So it's certainly no secret that our Native population, really benefits from the WIC program and many other health and social programs on their reservations. That's for many reasons, but in Montana in particular, I'll just highlight that I also think that's because of our rurality. There is not a lot of public transportation in our rural areas. There is not a lot of stores or services or doctor's offices. There's not a lot of cell service or access to internet, all kinds of issues with access. And what that results in is people not necessarily getting the services that they need and the food that they need on the table to be healthy. And that puts them at higher risk for a whole number of issues and conditions. So I will say that in WIC, we have a WIC clinic at all 7 of our reservations that have been established. And the Little Shell, we hope to, once they establish their health clinic, we hope to partner with them as well. But I just think that this is an interesting and clear description of the need in Montana. You can advance. Thanks. So just how we at the state are organized and why it is so easy to collaborate with our partners, and MIECHV being one of our top partners, is that we're co-located. We're in the same department, of course, of Public Health and Human Services. We're within the same division. We recently underwent a reorganization, but our bureau stayed together and we are in the same bureau. We were in Public Health and Safety, and now we're in the Early Childhood and Family Support Division, which has a number of other early childhood programs, such as like Head Start Collaboration, CACFP, childcare licensing, and so on, that we are now co-located and organized within. Our bureau is the Family and Community Health Bureau, and beyond WIC and home visiting, we also have family planning, Title V, which is MCH block grant, and within there we have our primary care office and oral health and our mom's grant and a number of other MCH initiatives, Children's Special Health Services, and MCH Maternal and Child Health Epidemiology. So as you can see, this group is a fantastic group of programs, and we benefit very much simply by being in the same building and working together regularly and always being in the same meetings. We have had a data sharing agreement between MIECHV and WIC since 2016. And I would say, I met Leslie and oriented to the MIECHV program when I showed up in WIC in about 2013. And we were both, I think, relatively new. I think Leslie had been there a year or so before me. But I would say immediately we gravitated towards one another and started talking about how we could work together. And within a couple of years had this data sharing agreement. The original use of the agreement was actually to gauge the effectiveness of our referrals at the local level. So we did a project back then in 2015 to data match in one local area and see how well we were overlapping with our families and what was the potential for more referrals. We just quickly pivoted from there to just using that agreement more broadly for outreach and collaboration. And we've had it in place ever since, and we just renewed it this year. So that has been a great tool. Advance. This is a map. The next 2 slides are maps of our programs and where we're located in Montana. This is the MIECHV program sites, and Leslie will talk a bit more about the sites and the models, but this is just a nice summary of where they're located with the little stars. Again, as you can see, just a very large state. The areas, it appears, where most of the stars are in our population centers. You have, Missoula and Great Falls and Bozeman, and then there are some more rural areas where they have sites as well, which is a huge benefit to those areas. Advance, please. The next slide here is our WIC program map. Ours is a little busier. We have not only a lot of WIC sites, but this also includes our breastfeeding care counselor program sites and our farmers market nutrition sites. So that's why all the bubbles and stars and squares and things like that. And then the colors here are our regions. So for each of those regions, the star in the circle that's yellow would serve the entire color of their region. And just to point out here, you can see, for instance, down in the southeast corner of the state, all the light purple there, where we have a star in Custer County, and we're going to highlight them later as one of our great collaboration examples at the local level, but they serve a massive geographic area, 6 counties, and it's very, very rural out there, easily 30 to 45 minutes between little tiny towns. And, you know, they only have 4 clinics, and that is really the best they can do. It's hard. It's hard to serve such a large geographic area with such a small population in tiny little towns. So it just hope that translates in this map. Advance, please. This is a great example of our collaboration. We're going on our 10th year of the Great Beginnings, Great Families Conference, and that Leslie could talk a little more about where it started, because WIC wasn't involved when it started. But over the years, it has evolved from, I think, primarily a funded conference by MIECHV and a training for their staff, and then also some of their really close partners. But it has expanded and grown so much over the years. And largely, it's become much more systems focused and bringing a lot of different people together who work, you know, with the same population or have crossover in interests. And so this is just a nice picture. It's a few years ago. This is our last in-person conference. The last 2 years were, of course, virtual. But this is so great. This is Leslie on the left with my roly-poly little girl when she was just a few months old. And the next person over is Rachel Donahoe, and she was the director for Children's Special Health Services, myself, and then Bree is the executive director for Healthy Mothers, Healthy Babies. So I think that just exemplifies, you know, some of our partners, who we work with, who we, you know, just, we all come together so beautifully, and it's such an effortless collaboration to work together on this conference. And then on the other side there, that was just me with the governor. He came, we always have a really important person to open the conference. It's usually the governor or director of public health, or, you know, lieutenant governor, or the governor's wife, someone from that realm to open the conference. And that's always very exciting to have them learn about our programs a little bit in preparing, and to speak to all of the workforce in early childhood. Just to expand a little bit on who participates here, it is not only home visiting and WIC, but we have Head Start and childcare providers and all kinds of other programs that come to this conference, all kind of tabling programs that come here. And so there's just tons of opportunity for networking and crossover and sharing of information. And in fact, at this particular conference, we had a whole session where we featured a few of our programs at a time. We did multiple sessions, and Leslie and I did one session together where we talked about WIC and MIECHV to educate each other's people on the programs. So that's a great example of something we would do normally in one of these conferences. Advance, please. So a little bit more about WIC. I mentioned that our participation is down. It's about 14,000 now. We serve about 9,000 families. I showed you the map, so I won't read all of those numbers, but we do cover the entire state. We actually have a total of about 85 clinic sites, but that includes like satellite clinics. We have just over 11 million in food redemption annually, and I think that's an impressive number just when it comes to our retail community and our farmers, knowing what a value it is to have this program in the state. We have 15 agency breastfeeding peer counselor programs, and they serve a total of 17 regions. Over 75, maybe even close to 80% of our participants have access to a peer counselor, because these are at the, these are at more of our population centers. We do, many of you may know this, but I thought it was worthwhile to highlight in case you're not terribly familiar with WIC. One of the things we do in WIC is we do health screening. So we collect heights, weights, hemoglobin. We do a brief medical history, nutrition assessment. We assess for substance abuse, perinatal mental health, food security. We assign risk codes related to any of those topics and many, many more. And I think that that's imperative because it overlaps quite a bit with what MIECHV does. There's a lot of assessment and referral that goes on in MIECHV, and I think it's really helpful for both of those programs to know that about one another so they can see how complementary they are. We also provide relevant education, participant-centered education, and we make referrals. So I have in bold their home visiting because that's one of our primary referrals that we make if there's a MIECHV site close to our WIC clinics. Medical providers, other assistance programs like SNAP, Medicaid, immunizations, of course. Forward. I'll pass it along. I believe the next slide is passing it along to Leslie to pick up on home visiting.
Thanks, Kate. I'm happy to be here, everyone. I'm just going to talk a little bit about home visiting and our connections with our local programs, WIC and MIECHV. So in Montana, we have 4 implementing models: Family Spirit, Nurse Family Partnership, Parents with Teachers, and Safe Care Augmented. So we, for a low population state, we have a lot going on in terms of home visiting. We are in currently 22 counties, and we had 253 referrals to home visiting, or from home visiting to WIC in 18 and 19. And of these 1,300 families, you can see that 807 indicated participation in WIC. So like Kate mentioned, we have a strong partnership, and we'd consider WIC one of our very top referral sources. Next slide, please. This map, we won't go into detail here at all here, but this is the map of the at-risk counties in Montana. And I really just wanted to show, I think this is a really good example of how most of our counties in Montana are at risk. And so it's not just a few here, we're dealing with most of the state. We are not in every single county. Someday we hope we are, but we are working hard to get there. Next slide, please. This is just some quick information in the MIECHV project. If you aren't aware, there are 8 priority populations that we are charged with targeting for services. And this is a breakdown of those 8 priority populations, the number of households, and the % of total households served. So I won't go into much detail there, but these will be included in the slide. So next slide, please. I really want to highlight our local programs here. So this is the local agency in Cascade County, and Cascade County is located about 90 miles north of our capital with a population of about 80,000. It is also home to an Air Force base, Maelstrom Air Force Base, where WIC and home visiting are co-located at the Public Health Department within this county, Cascade County. WIC in Cascade County is one of our longest standing programs and a great example of shared management between WIC and MIECHV. The programs share an outreach coordinator that serves both the programs with outreach program collaborations and referrals. Both programs do utilize the Connect referral system, and that is a secure web-based system for sending and receiving referrals among service providers all across Montana. And not everyone is participating quite yet, but that is growing, and Cascade is a fantastic example of that shared, robust system. Next slide, please. Cascade County implements Parents with Teachers and Safe Care under the MIECHV project, and they have been providing home visiting services under the MIECHV project since 2014, but they've been a Parents with Teachers affiliate since 2007. So they also received some state funding, and really in this last project performance period have really excelled in meeting and exceeding the Montana baseline and the national threshold for a number of measures. So this is a very strong program. Next slide, please. This is our example of our group connections. Some of you are familiar with group connections, where they come together and provide an activity for the parent and child that's enrolled in the program. And so this is a really great example of that. Next slide, please. And our last agency that we'll highlight really quickly here is Custer County, and they're called One Health. And next slide, please. One Health is located in Miles City, Montana, which is the county seat of Custer County. And as Kate mentioned, the rurality of our state, this is in eastern Montana with a vast geographic area. And they have a population of about 11,000. So compare that to Cascade County, quite a bit different, and a very large geographic area to travel. They have been funded under MIECHV since 2014, and really the highlight here is that the WIC director is in a dual role with as the WIC, as a home visitor, I'm sorry, and having that dual role allows them to attend meetings that perhaps maybe they wouldn't necessarily participate, giving the nutrition focus of WIC and then the family education for home visiting. So we think that that is a really strong example of how well they work together. And for example, they do attend a child protection team meeting, and I think that is something that not in our other in other counties that doesn't happen, where the WIC director would be present at something like that and then could potentially mitigate for any sort of referral there when we talk about nutrition and health of the young child. So I think that is about all, because I think I'm out of time. So thank you very much.
Thank you so much, Kate and Leslie, for the excellent presentation. The chat box has been especially quiet today, so I'd love to get you guys thinking a little bit and sharing. So I'm asking everyone, the attendees, the webinar attendees, if you can answer the question, why is collaboration important in your agency or in your line of work? So if you'd like to share why collaboration is important to you in your agencies, we'd love to hear from you in the chat. Next, I would like to welcome Sanda Hankins, Program Manager of the Port Gamble Skelem Tribe's Together for Children Tribal MIECHV Program and WIC Program, and Mark Boland, the Evaluator for the Tribe's programs. Sanda and Mark, the floor is yours.
Hello, everyone. Thank you for taking time out of your schedule to be a part of this webinar. I'm extremely excited to hear that I was extremely excited to hear that a space had been created for the purpose of providing an opportunity for collaboration and partnership between WIC and MIECHV. My name is Sanda Hankins. I am the Together for Children and WIC Program Manager for the Port Gamble Skelem Tribe. My personal and professional core values are compassion, respect, trustworthiness, and loyalty. When we improve on our own lives, the goodness spreads to our families and community. My leadership roles include behavioral health operations with an emphasis on medical and behavioral health billing. I've had training in many specialty areas, including trauma and recovery, sexual assault, chemical dependency, HIPAA compliance, anatomy, terminology, coding, billing, office management, auditing, and grants management. I've tried my hand at managing a retail business, went on to own my own store in Washington State. I studied criminal justice and psychology while simultaneously raising my beautiful family. I became a mom at the young age of 16 years old. I felt scared, alone, like nobody understood what I was experiencing. I'm now 38. I have 4 amazing girls, 22, 19, 14, and 3. I have realized how natural, unapologetic, uncompromising, courageous, and rewarding motherhood can be. Today, I'll be co-presenting with Mark Boland. So I'm going to turn it over to Mark Boland so that he can introduce himself. You can place a voice to the face and name. Mark, next slide.
Hi there. Yeah, my name is Mark Boland. I am an independent evaluator based out of Seattle. I work with a lot of different organizations on different evaluation and research projects, and have a lot of projects with the Port Gamble Skelem Tribe. I've been the evaluator for this home visiting grant since the onset, which I think was in 2011. So pretty familiar with the particular grant, the requirements that we have in terms of collecting data and reporting and using data for program purposes. So, welcome.
So thanks for sharing, Mark. And we're so fortunate to have Mark as part of our team. I don't know how we do it without him. So thank you, Mark. I want to start by sending a great big hello to all of our partners out there, our extended team. I'm truly excited to have been given the opportunity to share with all of you today. I want to touch briefly on the contents of what will be shared. Please keep in mind, I do tend to go off into left field sometimes, so I may not keep to what I've outlined, but here is my hope. I'm honored to share a bit about the Port Gamble Skelem Tribe, sharing tribal structure with an emphasis on our specific division. I'm excited to then share about our team, our amazing team, Together for Children's mission statement and curriculum, the home visiting staff use. Mark's going to share a little bit about data with all of you, and then I'll move on to talking briefly about PGST WIC services and then take you on a bit of a journey through Together for Children's world of integration, of integrated WIC and home visiting services. I will then move on to sharing our world of collaboration that goes beyond our team and trickles out into both the tribal and extended community, with a data story shared by Mark right in the middle. I will share some benefits. Mark will talk about increased data collection, and then I will provide a glimpse into what our team believes to be some of the barriers associated with the integrated services we provide. So in sharing about the tribe, I thought it only proper to start off with Port Gamble's vision and mission statement. So let's begin with the vision statement. Our vision is to achieve the full potential of Port Gamble Skelem Tribal sovereign nation to be self-sufficient, proud, strong, healthy, educated, and respected. A mission statement. The mission of the Port Gamble Skelem Tribe is to exercise sovereignty and ensure self-determination and self-sufficiency through visionary leadership. We will ensure the health, welfare, and economic success of a vibrant community through education, economic development, preservation, and protection of the rich culture, traditions, language, homelands, and natural resources of our tribe. The Port Gamble Skelem Tribe is located in Kingston, Washington. As of June 30th, thanks for pointing out, Mark, in 2021, there are 1,337 enrolled tribal members. Over half of the tribal members reside on the reservation, and many others live just adjacent to the reservation. Major employers for tribal members are tribal entities, tribal government, and tribal services. All tribal services are located on the tribe's reservation. The tribal center houses a variety of administrative offices, including natural resources. The House of Knowledge is located next to the tribal center and includes the Career and Education Center, Longhouse, Elder Center, and Little Boston Library. A Veterans Memorial is located on the west side of the Longhouse. The Housing Authority, as well as the fully integrated medical, dental, and behavioral health clinic are adjacent to and across from the library. Early childhood programs in the Cultural Resource Building are in this same area as well. At the back of the tribal campus is the building that houses public safety, court, and children family services. On the north side of the tribal center is a youth center that features spacious areas of recreation, arts and crafts, and computer use, as well as high-tech media studio and a covered outdoor patio for youth activities. Gliding Eagle Marketplace is located in the south entrance to the reservation and has a separate espresso stand. The Point Casino is located just up the hill on the highway next to the Gliding Eagle Market. Together for Children, Home Visitation, and WIC fall under the Children and Family Services Division. This division includes Indian child welfare, family assistance, youth services, foster care, child support enforcement, elders, and vulnerable adults. Now, with that brief overview of tribal structure, I'm eager to begin sharing Together for Children's story of integration and collaboration. But first, let me introduce you to that amazing team I mentioned before, my dedicated team. Together for Children consists of some pretty awesome individuals. Every day, our team strives to provide outstanding services to not only families, but anyone who seeks support. The strength of this program lies within our commitment to functioning as a unit, as a team. We encourage and build on one another's strengths, and we value each person's individual abilities. From right to left, I will share the team I am fortunate to call my own. On the left, Adele Stokes, our nurse home visitor. Adele has worked with the tribe for over 12 years as a home visitor for 3, previously working with the medical clinic as a nurse and then with behavioral health and the prevention team. Adele has a significant background in working with medically fragile foster children, as well as medical service and in a mental health setting. Adele raised 5 amazing boys and often shares hilarious, sometimes nail-biting stories. Her animation can place you right in the story she's sharing. Adele makes us all laugh, yet she is the calm to our storm. Judy Dakota, our lead home visitor. Judy has worked with the tribe for over 30 years, assisting with various important roles and ultimately landing where her passion called her home visiting. Judy has been part of the home visiting team since the beginning, when this program was funded through the first MIECHV grant cycle. We often joke and comment that Judy just knows when someone gets pregnant. Judy has worked with the caregivers of the moms who are now enrolled in our program. She reminds us that compassion and vulnerability are skills we all should lead with. Leslie. Leslie is a registered dietitian, nutritionist, lactation consultant, and a health education specialist. She believes early access to nutrition and lactation education is important. She has worked in maternity support services in at least 12 local agencies, including almost 10 years in tribal programs and 4 years at the WIC state level, helping develop policies, trainings, and supporting breastfeeding peer counselor program. She also takes time to teach nutrition classes to people in recovery once a week. She enjoys yoga, gardening, and spending time with friends and family. Now, although this is the Port Gamble Skelem team, we do have an extended support team that is there with us every step of the way. The support provided to MIECHV funded programs is by far the most significant support system I have experienced and an outstanding example of successful leadership, holding it all together for us in so many ways. Together, the vision of Together for Children is to create a system of support for Port Gamble Skelem families expecting or raising young children that allow them to be successful, parenting emotionally and physically vibrant children who will flourish in life. We strive to strengthen and improve programs and services, improve coordination of services with an emphasis on at-risk communities, and identify and provide comprehensive services to improve outcomes for eligible families, specifically those who reside in at-risk communities. Our home visiting program is funded through tribal MIECHV. Paired with the Parents as Teachers curriculum, home visiting staff work towards enhancing the health and wellness of tribal communities. The Parents as Teachers model has been tested by rigorous peer-reviewed studies and shown to produce results. The model is designed for providing services to families with children from prenatal through kindergarten. Our specific home visiting program serves prenatal through 3 years of age. The 4 dynamic components of the Parents as Teachers model are personal visits, group connections, resource connections, and child screenings. Staff are only given access to curriculum and able to use this with their families once they are fully trained. All visits, screenings, and really anything pertaining to that family is collected and entered into our database, Penelope. Parents as Teachers provide support to affiliates to meet essential requirements of the model, as well as further quality standards that represent best practices in the field. An affiliate APR is completed annually to ensure those standards are being met. So let's talk a little bit more about our data. At this time, I want to welcome Mark Boland to share with all of you.
So as part of the project, we need to submit data. There are required elements, both for Parents as Teachers and also for the MIECHV project. We submit reports every 3 months reflecting services that are provided to families, and then we compile a full report submitted in December of each year. We collect a lot of data on different kinds of benchmarks, outcome measures, and just wanted to note a few so you can see some of the things that we've been proud of in terms of program successes. We tend to work with a fairly small population each year, maybe 25 to 30 different families. It's a small tribe, so a small population. We completed in the past, in 2020, we completed over 222 encounters with the home visiting staff. That might include alternative encounters or actual visits through the PAT curriculum, which is about 93% of all the recommended home visits that we need to do with those clients in the period of time. In terms of immunizations, which is another thing we need to track, we have a 97% immunization rate, meaning that of the children in the program, 97% of them have received their full complement of immunizations in the period of time. One of the other things we measure is initiating breastfeeding with moms. This is a measure that when home visiting started the tribe a long time ago, it was quite low and has steadily increased. And in the past year, 94% of the moms enrolled in the program initiated breastfeeding shortly after the birth of the child. We complete information on well-child visits, information that comes from the healthcare provider. And we found that 81% of the possible well-child visits that were supposed to occur for these children did occur. And in combination with the curriculum, we have to complete certain screening tools. There's a tool that measures economic strain. There's a domestic violence screening tool, ASQ, which is developmental screening. There's a child injury prevention tool, depression screening, and substance use screening tools. And on average, we've been able to complete about 80 to 100% of the specific assessments and screenings with the clients in the program. So we're pretty proud of some of these things that we've kind of laid out for you and see it as a positive in terms of the success of our program. So I'll pass it back on.
Thank you, Mark. I'm sure everybody listening is eager to hear more about our integrated home visiting and WIC services. So let's dive in a bit. In early days of tribal WIC, staff provided services at the tribe's medical clinic. At that time, medical, dental, and behavioral health were not integrated and were in separate locations. Wellness was up the hill, not within walking distance with our behavioral health. And medical and dental were fairly close to each other, but separate programs. WIC was staffed by a registered dietitian, and separation of duties were maintained through collaboration with the front desk staff. However, funding for this position did not cover the wage of a full-time registered dietitian. Our only WIC staff, and certainly didn't cover any of the time for front desk staff when they were assisting. Although each tribal location serves families in different ways, funding doesn't appear to be as flexible. Ultimately, the decision was made. Either another department would be identified to integrate WIC services, or WIC services would be discontinued through Fort Campbell. After several discussions and the hopes of continuing to provide these much needed benefits, these amazing benefits to families, Children and Family Services chose to integrate WIC into the tribal home visiting program. The Together for Children and Teen currently provide WIC services to both tribal and extended community. Home visitation and WIC have similarities, connecting families, providing education and guidance. Through WIC services, our team's focus is primarily geared towards shopping for healthy foods, preparing these foods, supporting families who breastfeed, and connecting families to a wide variety of resources and providers. Integration of the two programs had its bumps and bruises, still does, and although the population being served is similar, and both programs have similarities, home visitation and WIC are different. Training to provide WIC services was a significant undertaking. Shortly after introduction of WIC, there was a database shift and Fort Campbell was asked to participate. Everybody was in fact asked to participate. Staff providing home visitations, however, were now learning to provide WIC services as a pilot site for Cascades, all while gearing up to transition from, or in the midst of transitioning from nurse-family partnership to our current curriculum model parents as teachers. For home visitations. The change in WIC database required additional layers of learning, same as parents as teachers, and is still a huge undertaking today. We are fortunate to have the Washington State WIC team as our support. So essentially, staff had to learn to provide home visitations following essential requirements of a new model, while continuing to be mindful of our WIC implementation plan, while simultaneously training to provide WIC services as a pilot site and identifying ways to best integrate the two programs. Needless to say, challenges presented and continue to present. Staff do feel overwhelmed at times. COVID has added an extreme layer to all of that. We continue to go through challenges associated with providing both services. And by all means, I say continue because I do have a pretty significant audit that I need to respond to by next month. So we are definitely exploring the systems and like I said, still have those bumps and bruises and learning. And we are fortunate to have those amazing teams that we have. Once integrated, staff were truly able to understand the extent in which services were similar. And the data could be of great use in both WIC and home visiting, should a family engage in both. After all, the majority of families served are eligible for both programs and eligible for services through the majority of tribal and extended community programs. So let's talk about that for a moment. Let's talk about our significant efforts towards collaboration. I'm a huge advocate for wraparound integrated services, all of which are strengthened by increased collaboration. Together for Children staff dig in deep and won't settle for anything less than active collaboration between tribal programs. We have a memorandum of understanding in place with many of our collaborating partners. Programs located within the Children and Family Services Department fall under an umbrella supported by our department's attorney. Upon enrollment in home visitation, families review and sign program-specific documents located in their TFC intake packets, some of which pertain to HIPAA, family rights, and mandated reporting. Our team looks at opportunities of collaboration through an added lens, though. We request permission from families prior to moving forward with collaboration that is outside the immediate service we are providing. So what this means is that although we have memorandums in place, our team makes every attempt to connect with the family, request permission, and obtain releases of information prior to connecting. Once documents are signed, they are scanned into the family's electronic file, once again in Penelope. By doing so, Together for Children staff are able to continue building relationships of trust and confidence. The last thing we want to do is create a barrier. And I think it's worth saying over and over, we're going to be successful if we build trust with the families we serve. So we do not sidestep building trust unless an event triggers us to do so. From the beginning, communicating our individual roles and emphasizing our prioritization in the health and safety of our most vulnerable population, our children, helps families to understand that there are situations that require our team to follow through with mandated reports. And now circling back to collaboration, I'd like to share about a handful of the collaborating tribal partners right here, all within the same building or within walking distance. Integrated health services. So medical, dental, and behavioral health are now fully integrated and housed in one location, all within walking distance. I would say maybe a block away from our building, the social services division. So Together for Children staff collaborate and coordinate services with medical staff on all levels. We often share concerns about a child who does not appear to meet milestone markers, discuss supporting a family whose child is deemed failure to thrive, verbally discuss referrals for mental health or chemical dependency, and work with providers to obtain WIC prescriptions. That's just to name a few of the things that we really coordinate with those providers on. All Together for Children staff have access to electronic health records, the database that's used by medical, dental, and behavioral health. Access to this database provides our team with access to specific medical appointments, helps us to identify medical appointments that may need to be scheduled or rescheduled, or simply provides us with an angle to help remind families of any immunizations and well child visits that are past due or needed soon. And providing our team with access to health data that may have been missed or left out during a one-on-one discussion with the family. Oftentimes we get really wrapped into what we're doing, and some of those questions just don't come up, or possibly the family forgets that they had the appointment between the last visit. So access to that database has been a significant help to us helping families. Additionally, Together for Children staff have access to and are able to pull immunization records directly from the Washington State Immunization Registry and are able to access One Health Port to obtain status of medical coverage. Together for Children staff meet face-to-face through Zoom meetings or over the phone with health service providers as often as needed. Home visiting team has been asked to attend meetings and with potential healthcare providers and assist with development of job descriptions specific to those providers, the most recent being the hiring of an obstetrician. Home visiting staff have access to sending and receiving referrals electronically through the electronic healthcare system. Our team has participated in multiple trainings around this specific process. So all providers on the same page as our team and referrals are as fluid as possible. The information accessed through this collaboration is used when facilitating both home visits and WIC services. Collaboration with early childhood. So collaboration with health services is really just the tip of the iceberg for our program. The Together for Children team is in constant communication with our early childhood center, supporting families' needs through in-person collaboration and data sharing. Together for Children staff access ASQ results through an online database that is used by the tribe's Early Childhood Learning Center. Their team uploads the results obtained from ASQ screeners conducted by their staff. This access ultimately reduces burden to families through prevention of duplicate requests. So we're not asking them to do another ASQ screening when they may have just had one through the Early Childhood Center. Both Together for Children and the Early Childhood Department conduct advisory committee meetings. Currently, our teams are in discussion about the possibility of combining the two. Our hopes is to create even more collaboration to support families in the most unified way. Our Team's most recent collaboration efforts are assisting ELC staff with adding breastfeeding areas to specific classrooms within the center and coordinating future read to classroom events. So collaboration with Children and Family Services, as mentioned in a previous slide, Together for Children and WIC services are part of the Children and Family Services Division amongst Indian Child Welfare, Foster Care, Child Support, TANF, Food Bank. All programs are housed in the same building along with the tribal court and tribal police. Program managers meet often to discuss potential services, add additional preventative services that teams are gearing up to offer, and changes amongst the departments and within the tribe that are relevant to all staff and enrolled families. All CFS program staff meet annually at a minimum to look at bigger picture items, share updates about each program, individual program, and brainstorm expanding services, all while emphasizing the importance of and supporting the mental health of one another. It's more common than not for the Together for Children team to walk a client over and provide a warm handoff if the need for a service has been indicated. That isn't just within our department. We do that with 4 families, or we provide that support to families to almost anywhere they need it. So if we need to walk across to our health clinic or to our somebody in our behavioral health department and provide a warm handoff, we're going to do it. All of our tribal programs are extremely connected in that way, and it's more common than not for that to happen to us as well, right? So we receive referrals that way. A lot of our referrals come from word of mouth, so the majority start there, but we do receive a lot of referrals from a lot of these other departments, and often, like I said, with a warm handoff. With that being said, I'd like to again hand it over to Mark Boland to share a story through data.
Thanks. So one of the things that we're able to do with the Port Gamble Skelem Tribe is, so the tribe is the first native reservation organization to manage its own foster care program. So it's, for a number of years, run its own tribal Indian child welfare. And we have access to information about participants, both in the Together for Children program, the home visiting program, and the child welfare program. And we were able to kind of look back and forth to try and get a sense of, is there any connection between what's happening in these programs? And one thing that really jumped out that was quite interesting is that what we found is that over the history of the Together for Children program, which goes all the way back to 2011, but really just got started full implementation around 2014. So over the history of the period up through about 2019, which coincided a lot with our first grant period, about 20% of the Together for Children clients eventually ended up with an open dependency case with the ICW program. But when we looked at a subset of those who would participate in the program after full implementation, which was probably about mid-2014 on, this rate dropped to only 8%. We also found that the number of open ICW cases with children under 5 in the period between 2016 and 2019 is about half the number that we saw in the prior 4-year period. So there's some belief, as we look at it, that the Together for Children program engages a high percentage of the tribal families in a prenatal period. They work with them at kind of a crucial period when many of them actually are at risk for open dependency cases, and are often dealing with some of the issues that perhaps in the past, if identified at pregnancy or shortly after the child was born, that might have prompted kind of an open investigation, are now being dealt with quite nicely by the home visitors in working with those clients. So that connection has been important to us. It's huge to be able to show that there's some kind of connection between child welfare outcomes and the use of tribal home visiting programs. Sanda?
Hey everyone. Hey Mark and Sanda. Thank you so much. We're going to move on. I'm so sorry we're not going to be able to do these last slides, but we need to make sure that we have enough time for our partners in Georgia to give their presentation as well. So a sincere round of applause to you both. So much inspiring information today. So thank you both.
Thank you.
Yes. We're going to finish out east today. We've had a lot of time out west. With our last presentation today is going to be Georgia WIC and MIECHV. I am pleased to welcome Shalonda Smith, the Georgia WIC Breastfeeding Program Specialist, and Twana Nelson, the Georgia Deputy Director of the Maternal and Child Health Division of Health Promotion at the Georgia Department of Health. Shalonda and Twana, over to you.
Thank you so much for the kind introduction, and we will share a little bit about the state of Georgia and how we have collaborated between WIC and MIECHV. Next slide, please. So the objective today is to share with you state and local examples of how the WIC program and MIECHV have strengthened its partnership with the focus on creating a referral loop, implementing collective impact strategies, and strengthening workforce development, training development. Next slide. So just to tell you a little bit about Georgia, Georgia is by population, it's the largest state to the east of the Mississippi. Our population is 10.6 million. And for those of us who work downtown Atlanta, we'd say 9 million of those people are downtown Atlanta. If you've ever been, you probably know what I'm talking about. We have 159 counties, and that is divided up as 18 health districts or local agencies. Next slide. Now I'm going to turn it over to Twana.
Well, good afternoon, everyone, and we're so excited for this opportunity always to talk about Georgia. Our WIC program, phenomenal, and our home visiting program is very robust in our state. So always eager to talk about both programs. Just so you know how we're organized in Georgia, just like Montana, we are managed by both of our programs, MIECHV and WIC are managed by the Georgia Department of Public Health within health promotions, where Latoya Osmani is our division director. We have been really, really intentional about making that connection at the state level, and then also encouraging collaboration at the local level. We have one home visiting program that is actually located in a health district in a public health department, which makes it really easy for that program to be able to manage to build the rapport, to be able to collaborate internally with WIC and other public health programs. But the majority of our programs are external to public health. So they don't have that same luxury of being able to, walk next door to WIC or have that kind of connection. So we really thought at the state level it was vital for us to make that connection for our program. So we started off really simple. So what we did was to make sure all of our MIECHV programs at least had a contact, to their WIC departments and vice versa. So they were able to make that connection locally. They were able to reach out to their WIC contact to talk about, possible collaboration if they had questions about WIC. So we started really simple, just making that connection. Shalonda was really instrumental in making sure that we had the listing of the breastfeeding coordinator. So we provided that list to all of our home visiting sites and really put it on them to make that contact at the local level. And we also encourage our local WIC breastfeeding and MIECHV programs to collaborate. So some of our programs have really been successful at doing this. Before the pandemic, a couple of our sites actually did home visiting together. So let's say, for instance, if there was a mother who was having challenges with latching her baby, then she would reach out to her peer counselor and say, hey, I want to go on this home visit with me so that we can support the family. And they did that. Or she would tell, that mother, reach out to your peer counselor if you're having challenges, something as simple as that. Or she would reach out to the breastfeeding peer counselor and say, I was in the home with the mom was having challenges with latching, maybe you should give her a call and see if you could support. So all of that comes together just to make sure that the mother she feels supported and she has, all the tools and support for successful initiation and continuous breastfeeding duration to increase the duration of her breastfeeding. So we also at the state level conduct joint activities around health observances like World Breastfeeding Week. We have in the past participated in an event such as like Latch on the Lawn, and that was where families come together or mothers come together. They talk about breastfeeding, they promote breastfeeding, just sharing, together. So this was definitely an event that WIC and MIECHV supported. And then we also provide educational opportunities, and Shalana definitely will get into that in just a few minutes and tell you more about that. Also on the local level, we encourage our programs to host joint community activities. And these could be just something as simple as recognizing breastfeeding moms. I know we had one program that actually had a tea for the mother. So, they're really creative in how they are collaborating at the local level. And then we were really fortunate to be able to have some of our home visitors become certified lactation counselors. This was huge for us, being able to do that and having, the home visitor going into the home and they can provide that services to their families. But, it wasn't as easy as they thought it was going to be. You have the certification, but how do you use it? So, they were asking for support and assistance with that. So we thought that what we would do would pair them with their local peer counselors. So we made that connection. So they had someone that they could call to make sure that they were providing the correct information to the families, to give them support and encouragement on being able to talk to families about breastfeeding. So that was really good for us too, to be able to have our CLCs and then connect them to the peer counselors or the breastfeeding coordinators in their area. And then we also share program collaterals like brochures, flyers, and fact sheets. So definitely our home visitors are providing those collaterals to families and the resource information that they're sharing with the families. And then the home visiting programs also are able to put their brochures in the lobby of the public health department, where WIC families are coming in and other and coming in from WIC services and other public health services. Next slide, please. So I'm sure most of you know what Title V is, but for those who do not or not familiar, Title V operates as a federal-state partnership through the state block grant, which provides funding from the federal government to state government to promote and improve the health of women, infants, children, and youth, including those with special health care needs and families. So breastfeeding is one of Georgia's Title V performance measures. So Shalana and I are responsible for this measure jointly for MIECHV and WIC. So our annual objective for this is to increase the number of MIECHV and Healthy Start women who are referred into WIC services, including breastfeeding support. So our activities that we came up with was to connect the local MIECHV programs to WIC breastfeeding coordinators, and just like you heard me say that previously, describe that, and also provide education to the home visitors that Shalana will tell you more about. So we're really excited about, what we've done thus far with the collaboration between WIC and MIECHV. We know there's so much more that we can do. I've actually picked up some ideas just being on listening to this webinar on how we can strengthen our relationship. But we're so excited to be able to partner with MIECHV, with Title V and with WIC to increase the number of referrals into WIC and to support our breastfeeding moms. Next slide, please. So we also wanted to create this continuous referral process. So we wanted WIC to refer into MIECHV, MIECHV to refer into WIC, WIC to refer into MIECHV, that continuous process of referral. So we wanted to make sure those families that were in WIC that were eligible for MIECHV, that they were getting to us, and vice versa. So we make sure that our home visitors understand the services that are provided through WIC, and they're able to articulate that to the families. So they are definitely encouraging families to get certified, to go in for recertification, to take advantage of the farmers market, to take advantage of the other services provided by WIC, like the breastfeeding services, and also to simply use their vouchers sometimes. So the home visitors are there encouraging the use of WIC. And on the flip side of that, so we've had in some areas where we've been able to do in-services for WIC. So we've educated the WIC staff on exactly what MIECHV is, and they're able to articulate, the services that we provide. So they understand that we provide resources and support, screening and assessments, all through evidence-based curriculum. So we're able to do that kind of continuous referral process in both programs, understanding the other and able to articulate about the program. So we definitely want to maintain and strengthen, the synergy that we have between WIC and MIECHV. But I think we've done a really good job thus far. And I'm going to turn it over to Shalana, who's going to talk to you more about that workforce development and training.
Thank you so much, Tawana. Next slide. So we have been very intentional in the Georgia Department of Public Health about training and developing our staff to meet the needs of families. And one of the things that we decided to do within DPH is to partner to provide training to home visiting staff, home visiting site supervisors, first step screeners, as well as our Department of Public Health's Fatherhood Initiative staff. Next slide. So what that has looked like is within Georgia, our breastfeeding peer counselor training, the past curriculum, there's a new curriculum now, but the curriculum that we were using, Love and Support through breastfeeding peer counseling, we use that curriculum, and we actually from the state level do a centralized training of all of our peer counselors across the state. And so we opened up that training to the home visiting staff. And the idea behind doing that is to make sure that our families, as many of the panelists have shared this afternoon, we are serving the same families. This allows us to provide our families with consistent messaging about breastfeeding. So we actually share, and we have our home visitors come in for our peer counseling training. COVID kind of threw a wrench in it where we kind of got behind schedule a little bit with how we wanted to do that. But actually, I'm in the second training today. I'm taking a break from it to do this. But we have trained about probably 40, maybe somewhere between 30 and 40 home visitors across the state, giving them the exact same training that our breastfeeding peer counselors receive. So they are learning, as you can see, topics about helping mom say yes to breastfeeding, talking to mom about that first month of breastfeeding, when things don't go as planned, and then those critical topics and in regards to hand expression, baby behavior, feeding cues, and all of those pieces. And thus far, it has been an incredible resource. It's been so great having the home visitors in that training. And they have really enjoyed the, I want to say, intense and more in-depth training that our peer counselors receive. We have created pre and post tests where we will be measuring, the amount of knowledge and the degree of change of knowledge, rather, that our home visitors have received since completing the training. Next slide, please. So just to give you a little insight in regards to our DPH Fatherhood Initiative training, we devised a training that was called In the Zone for Win and Advancing Breastfeeding Through Teamwork. And this training was actually targeting fathers and teaching fathers about the critical beginning to breastfeeding. And we like to call it within our Georgia WIC program, we kind of say the power of three, where we talk about the first 3 days of breastfeeding. And we talk about some of those critical and important things that happens the first couple of days. And we talk about how moms need so much support the first couple of days. And we give dads little things that they can look for and ways that they can support mom. Next slide. Tawana?
Thank you, Shalonda. And we're almost done here. So some of our next steps that we're looking to do in Georgia. So we want to employ strategies to strengthen partnerships between the local and state WIC and MIECHV programs. So looking at what works, so the best practices from the different programs around the state, and also from other states, and how we can strengthen what we're doing here in Georgia. We want to develop a partnership handbook for WIC and MIECHV, for our MIECHV programs. And we've done this for a couple of our other MCH programs. And we want to do this for WIC and MIECHV, the MIECHV and WIC program. It's just a guide on, how you're able to partner, what's allowable, how can you partner, what's the best practices for that. So definitely to create a handbook in our state. Also, we want to implement techniques to increase the number of referrals between programs. That's really important to us. So we're definitely going to concentrate on that. And then engage in joint marketing opportunities. So as Shalonda said, we within the MIECHV program, the section that manages the MIECHV program also manages our fatherhood initiative. So seeing how we can marry all that together, our fatherhood, our MIECHV, and our WIC program, our breastfeeding, to say, fathers are vital to assisting mothers with best breastfeeding. Fathers are vital for, everything we're doing in home visiting, and putting some messaging out there and marketing around fatherhood and home visiting and WIC. So we're definitely something that we want to look at doing in the future. And that's all we have. We're really excited about the partnerships that we have. Shalana and I, we meet regularly. We're in the same division, in the same department, managed by the same division director. So it makes it easier for us to be able to partner at the state level. And then on the local level, our sites are eager. They're eager to reach out. The MIECHV sites are eager to make that connection with WIC because, like I heard one of the other sites, most of our referrals come from WIC. So we definitely want to make that connection, but we also support WIC and those families because we're able to go into the home. So we're able to reinforce, some of those positive activities and some of what WIC is giving them in the home to the family. So I think this is wonderful. When I got the letter about at the federal level that there was a push to be more collaborative, to have more collaborative spirit, that we were eager with that it definitely trickled down to us, and we started definitely working together immediately. We had already been working together, but more intentional about what we're doing in the state. So thank you for the opportunity to share for what from the Peach State, and y'all have a great day.
Wow, thank you, Georgia, and thank you to all of our presenters. I'm sure the audience is feeling inspired about ways that they can collaborate with their respective agencies. So we maybe have time for a couple questions. I see the chat box has gotten busy, so I'm glad to see all of your idea sharing, and you're able to talk back and forth a little bit, but we'll see if we can get a couple questions answered. One question I got early on was, we at MIECHV know that many WIC participants would benefit from home visiting, but referrals are more challenging to make while WIC appointments are remote. How have others coped with this? I guess let's hear from Montana first, since we haven't heard from you in a while, and then we can see if anyone else has any ideas as well.
I'll be honest. I mean, I think I'm sure we're facing that same challenge here. Everything is remote in Montana right now, and we, like many states, have had our surges and our lulls. But I've heard from our locals that connecting to referral sources is one of the harder things that are happening right now. We did create a contingency plan and have a dietitian on backup to provide support to our local agencies if they go down because of COVID, because we have very tiny agencies and a lot of our WIC staff are public health nurses. And so that's really, really hard when it's a tiny health department responding to a big outbreak. And so we have staff from other agencies who are assisting. And one of the tools that we created recently was a referral list for the local area. So like if another agency is covering, they know exactly who to contact for different referrals. That way, because they don't know each other's communities. So that is one tool that we've used in this time. I'm going to guess, though, that the referrals have also just declined this year. It's been hard.
Maybe for Gamble, do you have a quick answer? I think I maybe have 1 minute left for a question for the answer.
So I'm sorry, I had somebody step in. So if I remember what the question was, it was specific to, have we seen a decline in referrals?
Yeah, it was about how referrals are going with being remote.
Okay, so the majority of our referrals are through tribal programs, right? So a lot of our tribal programs have remained in services, either directly on campus or remotely. All activities resume. We have not seen a decrease in referrals. A lot of our referrals are verbal. We are connected to our families in multiple ways. And so we receive a lot of referrals that way. So we haven't seen a decrease in referrals. Yeah, no, not much, which is great.
Yeah, that is great to hear.
And I think all of our programs, or all of our services within home visitation are pretty much, our home visitors are at max caseload. So we haven't seen too much of a decline that way. WIC services, we have had a reduction in services provided. There are other services that are being provided that we believe may have taken the place of those, or it may have caused that reduction. So, but not referrals.
Great. Well, thank you so much. And thank you to all of our presenters. I'll go ahead and get to the next slide, please. In addition to the state and tribal resources shared today, this slide has some federal resources related to collaboration between the programs. And we'll send these slides out afterwards, so you'll be able to use these resources and maybe find out some information or answer some more of your questions. We would also value your feedback from today's webinar. In the chat, the link has been placed there. And so if you can go ahead and click that link and give us your feedback, we would greatly appreciate that. The link will also be sent out in an email as well if you missed the link today. And lastly, a big thank you to our presenters today and to all of you for tuning in to learn about opportunities for collaboration between MIECHV, WIC, and tribal home visiting. This concludes our webinar today. Have a great day. Thank you.